First, I'd like to recognize AAPS as being, as far as I'm concerned, the first major medical organization to recognize the direct primary care model. They saw it very early on as a grassroots free market solution to the healthcare delivery crisis, and they've been promoting it for many, many years through Thrive Not Survive conferences and advocacy. So without AAPS, I wouldn't have discovered DPC, and I wouldn't be nearly as happy as I am today. So much gratitude to AAPS. And my background, again, I was an early adopter of the DPC model in 2014, co-founder of the New England Direct Primary Care Alliance, a regional alliance of DPC physicians, and I'm the immediate past president. I was also co-founder of the National Direct Primary Care Alliance and was on the original board of directors, and as Dr. Huntoon said, current AAPS board member. Conflicts of interest? None. I thought it'd be useful to have a legal definition of direct primary care, and I'm going to quote the most commonly used definition, which comes from Dr. Phil Eskew, who is an AAPS member, not here today, unfortunately, but I think he's joining us remotely. So, hi, Phil. Thank you for all your work, because you could have probably given this talk a lot better than I could. So I'm stealing most of your material. Again, a DPC practice is a medical practice that charges patients a periodic fee, monthly, quarterly, or annually, does not bill third parties on a fee-for-service basis, and has to have any per-visit charges be less than the monthly periodic fee. In practice, in reality, DPC practices can be described usually as solo or small group practices. They contract directly with patients rather than insurance companies. Many also contract with small employers. Membership includes annual physicals, acute visits, chronic disease management, procedures, EKGs, point-of-care labs, etc. Most also do emails, text messaging, video visits, and phone visits as part of the membership. In most states, excluding Massachusetts, New York, New Jersey, and Texas, physicians can dispense medications under their medical license without having to be licensed as a pharmacy. You can do it at very low cost, which saves patients a lot of money and is incredibly convenient, so patients who are sick don't have to wait 2 hours to get an antibiotic at the pharmacy. They can just get it from their doctor and go home and go back to bed. Also, many offer cash pricing for laboratory services. Through group purchasing organizations, physicians can get labs from major labs like Quest and LabCorp at pennies on the dollar compared to what they charge insurance companies. And I found that many of my patients, from the savings on medications and lab fees, more than pay for my subscription fees. Some practices also offer additional services at extra costs, such as aesthetics, nutritional counseling, weight management, PRP injections, other rejuvenation medicine, etc. The nice thing about DPC practices is because you are not bound by insurance contracts, you have a lot of flexibility to turn the practice and mold it into what you want it to be. Some of the benefits of direct primary care. Well, they always say that you can have two, fast, cheap, or good. Pick two, right? I think in DPC you actually get to have all five things. You have affordability. Most memberships are $50 to $100 per month. Accessible. Same day or next day visits for most practices, high quality, and that's because the physicians actually have time to sit and talk with patients and do an adequate history and physical. Who would have ever thought that that would be a good thing? So you end up needing less referrals. You can handle more stuff in the office. So that leads to the fourth thing, high patient satisfaction. Patients are happy when they have a doctor, not just a clinic they go to and are seen by whatever provider happens to be there. And so they're happy, and guess what? The physicians are happy. They have better job satisfaction, stable income, and they get to practice medicine like they had hoped that they would when they first went into medical school and were very idealistic. Addressing DPC growth. Again, quoting Dr. Eskew from a study he had published in the Journal of the American Board of Family Medicine in 2015, he estimated that in 2015 there were 273 DPC practices. Fast forward 10 years, and this data comes from Hint Health, which is a platform that helps direct primary care practices do practice management. They estimated that there were 3,600 DPC practices. And they said that they calculated the growth since 2022 has been 19% per year. So things are rapidly growing, which I think is a really good thing. And this is a screen grab from DPC Frontier, dpcfrontier.com, which is Phil's website. And as you can see, there are a lot of DPC practices around, up and down the East Coast, all along the Gulf of America, and up the West Coast, and all throughout the Midwest. You even see there's one in the bottom right corner in Puerto Rico, a few in Hawaii, and not shown on this map, there are even a handful up in Alaska. So what I'd like to do is do some of the demographics, and this is as yet unpublished data that comes from the Direct Primary Care Alliance that I was able to get a preview of. And I think it's kind of interesting, some of these numbers. The median age of a DPC physician is 45, modal age 40, so it's kind of a young to middle age type movement. And I found even more interesting that 9% of DPC physicians do it straight out of residency. So these are very bold young men and women, and I salute them because I'm not sure I would have had the guts to do it. So I'm really proud of them for being able to do that. DPC practice demographics continued. More than 2/3 of DPC practices are 5 years old or less. So it's still very much a young movement, but it is growing very rapidly. Going to medical degree, 76% of physicians doing DPC are MDs, 24% are DOs, and there's 0.2% are bachelors of medicine and bachelor of surgery. So I think there must be at least one Brit doing it somewhere in the United States. And actually, what we see here is DOs are overrepresented in DPC. Nationally, I think 89% of the physicians are MDs and 11% DOs, but it makes sense that there are more DPCs or DOs are overrepresented since DOs tend to gravitate towards primary care more than MDs who tend to go more into specialties. And this is the statistic that really shocked me. Of the respondents of the survey, 68% are women, 32% are men in direct primary care. This could be because DPC, again, gives you a good quality of life and some flexibility, so I could see why that would be attractive to women, especially mothers. And in terms of specialty, 77% family practice, 12% internal medicine, 7% pediatrics, 3% med peds, and 1 or 2% other, probably GYN or emergency room. In asking respondents to the survey, is your panel full? 69% have availability for new patients. 31% list themselves as being full. And in terms of the practices that said they are full, we see about half of them, a little bit of a majority, define full as being 400 to 700 patients in their panel, which I think sounds about right. This is an almost bimodal curve. You see there's also a significant minority that go from 100 to 400, which I think attests to the fact that, again, this is a flexible model and you can tailor it to your needs. Some doctors, especially mothers who are raising a family, don't want to be as busy and do it almost part-time, just a few hours a day, and they manage a smaller panel, and that works out for them. As long as they calculate their overhead and can make enough money, it's a win-win. Barriers to DPC growth. It's a little bit frustrating to me because doing this for several years, when I come across someone from the media, come across a stranger just talking to them and they ask what I do, I tell them I do direct primary care. They give me a blank look and say, what is that? I've never heard of that. Which, national awareness campaigns are very, very expensive. And DPC practices, the new DPC docs, they're busy in their own towns trying to drum up business, but you're not going to be able to get a bunch of primary care doctors affording Super Bowl ads or major advertising campaigns. So it's very much word of mouth. So that does hamper its growth a little bit. Misconceptions about DPC. Well, it's concierge care, it's only for the rich. Well, I mean, I guess technically it is kind of a concierge care because you are paying a type of retainer fee, but again, it's third-party free, so it's not really the MDVIP or the concierge care that we think about, but nonetheless, oh, you just take care of rich people. But at the same time, they say, well, yeah, DPC sounds really great, but it'd be really good if you didn't have insurance. If you can't afford insurance, DPC is great, but once you have insurance, why would you need DPC? So, I mean, they want to have their cake and eat it too. It's for the very rich, or it's only for the poor people. So there's a little bit of a dichotomy there. And I remember one thing that people would say is, well, they just cherry pick healthy patients. So they don't really have to work hard. They make a lot of money. They're just cherry picking healthy people. And that argument's very infuriating because I have many, many, many patients who are not rich and who have many, many medical problems, and I spend a lot of time treating them. And it reminds me of something, and I think it was Keith Smith that said this at one of these conferences. He said, I don't cherry pick patients. Patients cherry pick me. So people that need more attention tend to love direct primary care doctors because we will give it to them. Another criticism of DPC is that it's not scalable. Well, how do you ramp it up and get as many DPC practices out there as you would need to meet the demands of big employers? And there's institutional resistance to direct primary care. Academia. I can't tell you how many times I've seen op-eds and thought pieces by academic physicians bemoaning that because DPC physicians cut their practices from about 3,000 patients to about 500, that this is going to worsen the physician shortage. Well, my retort to them is, well, you're in academic medicine, you're seeing 0 patients, so if it really matters to you, why don't you get your stethoscope, get off your butt, and get into the exam rooms, right? Insurance companies. You would think insurance companies would love direct primary care because guess what? We don't bill them. We don't generate claims for primary care to the insurance companies. You would think they would love us, but they don't, because they can't control us. They can't deny our claims, so they don't have control over us. They can't get us to do what they want us to do. And they frequently deny our referrals because we are not in any networks. So we have to work with patients and say, well, maybe you want to get a health sharing ministry, or maybe you want to get maybe a PPO so that you don't need a referral. As Larry said, in Maine, we were able to get around that with the law so that we actually work with the insurance industry, which was a really weird thing. Politics makes strange bedfellows, but they were willing to work with us to get a law passed that we could get our referrals through if we could certify that we were a DPC practice. Government. Well, who here doesn't know that government can be a threat to medical practice? There were threats to, there's always the threat that they could decide that, well, you're paying monthly for health care, that kind of sounds like insurance. Well, if a state Bureau of Insurance commissioner said, oh, well, yeah, you're an HMO, you're an insurance company, so the Bureau of Insurance is going to regulate you, not the medical board. Well, they could demand that you have tens of millions of dollars in your reserve accounts to cover risk. That would effectively shut down DPC in any state. Also, whether or not you can use HSAs, and we'll get to that in just a second. Again, thank you, Phil. This is another screenshot from DPC Frontier. Through advocacy and through physicians taking time off to go testify at the legislature, I did it. Many physicians across the country have done this. We've been able to pass legislation in at least 29 states that DPC is not insurance and therefore should not be regulated by the Bureau of Insurance, which would effectively, again, kill it in any state. So that's a win. Also, DPC and government. So I've been asked by several well-meaning people, said, you know, DPC's great, you take great care of patients. Maybe you could partner with the government to take care of Medicaid patients because, you know, they need good care and you provide good care. So wouldn't it be great if you could do that? And I think that sounds really nice in theory, but for those of you that don't know it, let me tell you about the cautionary tale of Q-Liance. I don't know how many people are aware of this. Q-Liance was an early DPC pioneer in the state of Washington. Garrison and Erica Bliss were the founders, and there was a lot of ballyhoo out there, and they got support from Jeff Bezos, Michael Dell. So they got a lot of money, seed money to start the practice, and they set up a chain of DPC practices that was actually doing great. They were really successful. They were having great outcomes. Everyone was very happy. Well, the state of Washington said, you know what? This looks really good. How about if we do a pilot program and you start taking care of our Washington State Medicaid patients? And they said, great, let's do that. And they did a great job. And they were able to take care of patients very efficiently, really good quality of care, and because they did it efficiently, they made a very nice profit. And the state of Washington said, oh, wait a minute, you're making too much money. You're gouging us. We're going to claw it all back. So the state of Washington took back a lot of the money that they had paid Q-Liance, and guess what? If you suddenly take a bunch of capital from a business that it wasn't expecting, it went broke. So Q-Liance was forced to shut down, declare bankruptcy, and they are gone. So anytime someone says, well, why don't you partner with government? I remember Q-Liance, and I think everyone here should as well. The The IRS, HSAs, and DPC. Previously, going back before the first Trump administration, the IRS tax code was silent on HSAs and DPC. So most of us felt like, well, it's better to be a quiet mouse. A quiet mouse is a happy mouse, right? Unfortunately, an IRS commissioner was asked by a senator to give his opinion on it. He said, oh, it kind of sounds like a secondary health plan. I don't think that would be good. Still wasn't in the IRS code, so it was a very murky area. So people prevailed on President Trump in his first administration to issue an executive order allowing DPC as an allowable HSA expense. You'd think so. Well, again, in Trump 1.0, he was naive to how deep the swamp was. IRS attorneys didn't like that, and a friend of mine was in the room with them trying to convince them otherwise, but the IRS attorneys said, well, I guess it has to be an allowable expense, but we think DPC is a secondary health plan. It's not just medical services. And if you have a secondary health plan, you are no longer, you don't qualify to contribute to an HSA anymore. So you can use HSA funds, but you can't contribute to your HSA, so you're just going to spend it down to zero. So that ruling was probably less helpful than no ruling at all. So, Trump 2.0. President Trump has come back much wiser and aware of the deep state than he was the first go-round. The one big beautiful bill passed on Independence Day, effective New Year's Day. DPC subscription fees are formally codified as an HSA allowable medical expense, and they're not a secondary health plan, so they're allowable. You can still contribute to your HSAs. In fact, DPC membership fees will also count towards your deductible now. So thank you, President Trump, and thank you, Secretary Kennedy, for that. So this will empower patients to seek DPC practices. And this slide is just kind of before and after the big, beautiful bill. But are there hazards ahead? And unfortunately, I think there may be. With respect to scalability, well, again, it's a big criticism. We're doing mom and pop practices, dealing with small businesses and individuals and families. Well, how's that going to take over the primary care field? Well, here come the middlemen. And I feel weird saying this, but not all middlemen are bad. They're fine if they provide value that would not otherwise exist. They facilitate, not interfere with the direct relationship between the doctor and the patient. They try not to own either the doctor nor the patient, and the reimbursement is reasonable and transparent. But unfortunately, these are unicorns. The rise of the PCMOs, also known as the dinos, and I'll explain why in a second. So primary care management organizations have arisen, companies that rise up to form networks of DPC practices that they either own or with whom they contract, so they can approach larger Fortune 500 company groups. They generally require the DPC practices to alter their usual practice patterns, sign contracts, do data reporting and quality metrics that they otherwise would not be doing. And they take the direct out of the direct primary care, which is why we call them dinos, DPC in name only. And they are basically recreating the system from which we all tried to get away from. So the question is, what will the effect be of the big, beautiful bill on the dinos? It remains to be seen. On one hand, you could say it's going to raise the profile of DPC, so it's going to embolden them to try and rake more doctors into these, I think, unfavorable contracts. But I would argue that it could incentivize employers to get out of the primary care business. just put money into the HSA, let the patients decide where they go. In fact, I don't even think you need to have DPC scalable at all. I mean, primary care years ago was not scalable. You saw your family doctor or your internist, and they took care of you. And if you needed to see a specialist, they sent you to a specialist. There's no need to scale DPC. It's just fine the way it is. And I wish that there are a lot of people out there that aren't satisfied with that. Last thing I'll touch on is a concern that I have about where DPC is going. The original pioneers and early adopters of DPC were bold. They were entrepreneurs. They were believers in a free market. They tended to be more politically conservative or libertarian, and they were willing to work hard to establish a business. I'm talking about, again, we all know the Josh Umbers and Lee Grosses and those types that were not afraid to go out there and do the hard work to get things done. But now, as we see, the movement is maturing, it's growing, we have proof of concept, and more people are being attracted to it because we know the pay is sustainable, the hours are better, the satisfaction is better, there's more flexibility, and now there are so many DPC practices that are hiring new physicians. You don't have to establish your own practice, you don't have to take on as much risk as you used to, so you can do that. So again, it's basically attracting a lot of Karens. And the old guard is starting to be replaced by the new. They're more politically liberal, more vocal and focused on gender issues and gender ideology. They're advocating at DPC conferences for DEI and health equity. And this is really weird, I can't figure this out, but many feel that single payer or Medicare for all is what needs to happen, but they're going to do DPC until that happens, and they have some bizarre notion that when that happens, they can function in that system under a Medicare for all, which I'm not really sure how that works, but that's what they think. And again, maybe because a lot of these folks are coming right out of residency, and again, we know that the medical schools and the residencies teach doctors that they need to be a cog in the machine. They're much more willing to look at contracting with government and even insurance companies, which really removes the whole, it's contrary to the whole concept of DPC. And so the question is, will DEI make DPC DIE? So that is a really big question. But what I would say, I know those last couple things I said were not very optimistic, I guess. I'm just expressing concerns. These things are not taking over DPC, but we have concerns. And it reminds me of a saying that most of you know, and I'm going to tweak it a little bit. Hard times make strong doctors. Strong doctors make good times. Good times make weak doctors. And weak doctors make hard times. So maybe this is all a cyclical thing. Maybe we can prevent it. But again, despite everything I just said, I have practiced medicine in just about every venue you can think of. I did it, I was in the biggest HMO in the world, which is the Department of the Defense, the U.S. military. I've practiced as part of a hospital practice. I've done private practice, accepting insurance. But I found that DPC is the only way I think anyone can practice primary care the way it should be practiced. And this is the only way I'm going to do it from here on out. And I think that more primary care doctors, especially folks like yourselves, need to go into so we can keep it as good as it is. And with that, I'll say thank you.